Hello, my name is Dr. Melanie Carminati. I'm the founder of Inspira Physical Therapy and Pilates here in Brooklyn, and I am very excited to have Dr. Allyson Shrikhande on to speak about pelvic pain. So I'm just going to introduce you first for those viewers who aren't familiar with you. So Dr. Allyson Shrikhande is a board-certified physical medicine and rehabilitation specialist, and she is the Chief Medical Officer of Pelvic Rehabilitation Medicine here in New York City. She's also the chair of the Medical Education Committee for the International Pelvic Pain Society. She works with experts in the field of chronic pelvic pain, developing training modules for residents and physicians interested in learning about the diagnosis, treatment, and management of chronic pelvic pain. As a leading expert on pelvic health, she has published peer-reviewed articles on the treatment of muscle pain in academic journals and works closely with renowned pelvic pain gynecologists and urologists. Her approach is multidisciplinary as she works with specialists in pelvic floor physical therapy. So Dr. Shrikhande, thank you so much for your time. Before we get into our chat, I just wanted to remind our viewers, yes, I see some people saying yay because we got it to work. For the first 5 viewers who give us a thumbs up in the comment section, we are going to be giving a prize. For those first 5, you will be getting a virtual Pilates class at Inspira. So we will follow up with you afterwards. Whoever the first 5 are, we will just send you a message afterwards, okay? All right, so I wanted to start our pelvic pain chat off with just discussing pelvic pain in general because it is broad. As a pelvic floor PT, I think of pelvic pain as pain that's in the lower abdomen, pelvic region, and then to categorize it into persistent or chronic pelvic pain. For me, that's if it's been longer than 3 months that it's been occurring. But I wanted to hear from you, what is pelvic pain, and then how do you categorize it?
Right. Well, yes, pelvic pain can be separated into what we call acute, subacute, and chronic. And technically, acute pain is less than 6 weeks. 6 weeks to 6 months is subacute, and then greater than 6-month duration is chronic pelvic pain. So the technical definition of chronic pelvic pain is pain that is localized to the lower abdomen, buttocks, lumbar sacral spine, and it's greater than 6 months. It can be actually intermittent or continuous, so it can come and go, and it cannot be related to malignancy or an active pregnancy. And it should be sufficient enough that patients either have some sort of functional disability in their bladder, bowels, exercise, and or they seek some sort of medical professional care.
Got it. So in terms of the populations that can experience pelvic pain, what are the most common populations that experience pelvic pain?
Yeah, so it can be men, so men or women. And in the female category, a lot of times there may be some sort of concomitant underlying gynecological disorder. Endometriosis is probably the most common one that we do see. You know, the data ranges from either 1 out of 10 women to a recent study out of Australia, 1 out of 9 women. So that would be your most common is endometriosis, but of course other gynecological issues such as adenomyosis, fibroids, sometimes even PCOS. And then we see some postpartum issues for the female population after having delivered a baby, particularly vaginal deliveries with some sort of either prolonged labor or use of forceps or vacuum-assisted deliveries can, predispose to pelvic floor muscle dysfunction and some pelvic pain postpartum. Overall, athletes really, in both the male and female population, it's that repetitive micro-trauma that happens to the pelvis. So we see quite a bit of athletes. And clearly bikers, sometimes biker syndrome is known to be correlated with pelvic pain, but really even young dancers, gymnasts, a lot of times the sacrospinous sacrotuberous ligaments, the posterior sacral ligaments, aren't formed as perfectly prior to the menstrual cycle coming. So gymnasts and dancers who start at a young age and are high level can have a predisposition to having some sort of pelvic pain. And with the male patient population as well, athletic, usually with that repetitive micro trauma, sometimes a hip injury over a long period of time, you'll eventually get some pelvic pain. And a lot of our male patients have concomitant hernias, and hernias are very, very common as well. And then lifestyle, right? A lot of sitting. So someone who travels a lot for work or has a long commute or sits a long day at work, you know, they're more predisposed.
So there was just a question from some of the viewers. Oh, someone actually answered it. They said, what is PCOS? And I was just going to announce that it's polycystic ovarian syndrome so that everybody would know what that acronym meant. So in terms of populations that are less known and maybe more underserved, what population would you say is more underserved with pelvic pain?
You know, I'd say both the endometriosis patients still,
Okay.
ironically, as a physiatrist, we are a lot of times on the front lines of it, really letting patients know about what it is and that, you know, they may have it. So I'd say there's still delay in diagnosis with endometriosis. And then also, I think our men with chronic prostatitis who, you know, taken so many antibiotics and NSAIDs and are a bit frustrated. So I think that there's not enough, you know, availability for treatment options for them. So that is partly why we created this protocol for those male patients.
Right. And so you touched on it essentially there when you were describing the populations, that the causes, it can be widespread. It's multi-system, it's multi-region, it can be different parts of the body, hip, lumbar, spine, you name it. How does that affect how you're treating? And what is the treatment approach for treating pelvic pain?
Yeah, no, that's great. So, you know, as physiatrists, we're kind of like the detectives when we meet patients. So, you know, we are completely used to looking at the body with putting the different organ systems together, as well as connecting the different organ systems with the muscles, the fascia, the nerves, and the joints. And that's really how we're taught. So that is how we would approach a pelvic pain patient as well. So we're really trying to figure out any, we call them predisposing factors is what we say, and the underlying predisposing factors for why patients would have the symptoms of pelvic pain. So that's what we're doing, and we're doing a full exam. It's really a neuromusculoskeletal exam, looking at the lumbar sacral spine, sacroiliac joints, coccyx, and then we are looking at the abdomen, the hip, looking at patients' hips, as well as their internal pelvic floor, internal, external pelvic floor, really looking for any predisposing factors or primary pain generators. Those are the two things we're looking for. And of course, with the history, a nice history from a patient can help lead us a lot. And then we do the proper workup if necessary. You know, we can order the imaging if we feel there may be something going on, and then we make a plan with the patient and we let them know what their predisposing factors are. Usually it's multifactorial because it can be it's a multifaceted, multifactorial disease process. But we discuss and then we go from there. You know, we continue workup if needed, and then we just describe a treatment plan to get the patient feeling better.
So thank you for that. So I was looking through your website and how you listed the triplex approach and how that included cognitive behavioral therapy and also meditation.
Yes.
So that is something, right? So that's something that you're frequently recommending and referring to patients as well, right?
100%. Really, every patient who comes in her door, we really require a mindfulness meditation process to really calm down that central nervous system and reset in combination with the diaphragmatic breathing. It really does help. So, you know, there's a couple apps that we like to recommend if patients really are insistent on doing it on their own. We'll have Calm is one that we use quite often, or Headspace. But then we actually have Dr. Shrikhande in-house. She has a telemedicine platform where she does one-on-one, and it's a cognitive behavioral therapy, but really a mindfulness-based CBT. And so she's also trained in addition to CBT hypnosis, and she's working on her sexual medicine training. So she's really focused only on pelvic pain, pelvic floor muscle dysfunction. And in addition, we actually created a course. Dr. Shrikhande leads it, but her and I created a course called Retrain Your Brain that is free for our patients. It's five sessions, and it's a group course, but it's teaching patients how to do the mindfulness on their own. A lot of muscle relaxation training, so just like visualizing, relaxing your different muscles of your body, particularly the pelvic floor. Just down training the nervous system in a group. So there's also the group class as well. So, every person's meditating. We really talk about the importance of it, and the recent MAP study, the multidisciplinary approach to pelvic pain through the NIH is really, it's shown through functional MRIs of the brain, right, pre and post, really how, it really helps, and it's been proven to really help and down-regulate areas of the brain that can really be causing that pelvic floor spasm and upregulate pain. So at this point, it's been proven, and everyone really should do it.
Wonderful. So the comprehensive approach is really key because there's so many things that influence it. I wanted to just hear from you, how do you put pelvic floor physical therapy into your recommendations for patients? And
Sure.
is it all diagnoses? Is it some diagnoses? And just...
No, it's all diagnoses. So as physiatrists, we're really extension of pelvic floor PT,
Right.
So we're for sure, it's a tag team approach. It's a multimodal approach for this disease process, and pelvic floor PT is key. It's so important. So we really, really encourage and really require patients to go, because, we just see that it's needed to get the patient better. So even, so say you've tried pelvic floor PT and then you come to us because either you plateaued or, you improved 50%, but you're looking to improve more. And then we do if we are doing the injection protocol, we have patients go to physical therapy that week. You have to go post-treatment, because it really helps create that space, right? Create the space around the nerves and around the muscles and the fascia. And it really is doing the same thing that we're trying to do. Calm down the nervous system, create space, increase blood flow, down training first, followed by a neuromuscular re-education when they're ready. But definitely have to work together as a team. And it's so impressive. I mean, our patients really, they go. I mean, they really do. They go to PT, they come to us, and that's what works. It's for sure you need both.
Absolutely. So you were touching on their time frame when patients are going to physical therapy and then they're coming back to you, and say that they're still having the residual symptoms, and you may do a trigger point injection, or I want to bring up the research article that I mentioned, the non-opioid based treatment approach to men with urological chronic pelvic pain syndrome, because that goes into the combination of trigger point injections for the peripheral nerves and trigger point injections, I'm sorry, for levator ani muscles, and then peripheral nerve hydrodissection, right?
Yes, and that is the protocol. We call it the PRM protocol, and essentially it's external, not internal. So it's external, ultrasound guided, combination of trigger point injection with the hydrodissection peripheral nerve block of either the pudendal nerve or its branches, the posterior femoral cutaneous nerve, ilioinguinal, or the genital branch of the genital femoral, really depending on the patient's symptoms and exam. But really conceptually, patients they go right to work. It's kind of like a dentist appointment, I guess. No anesthesia. You go sit on some ice and you go on with your day. You go to work and you can go to dinner that night, whatever you'd want to do. But so it's subtle, clearly, but we get you there. It's between that and some physical therapy, and it's one side at a time. And it's really one of the levator ani muscles at a time. So it's fairly subtle. And conceptually, it's important to treat both the myofascial pain and that neurogenic inflammation, that inflammatory soup that comes with pelvic pain at the same time. So that's what's unique about it. It's not choosing one or the other. You're seeing the importance of both of them, and you're treating them both simultaneously. In addition, you're treating the pudendal nerve and the posterior femoral cutaneous simultaneously because they upregulate one another. I describe them almost as best friends, and there's a significant amount of overlap in their distribution. So if one's not happy, the other one's not happy. So that whole cross-sensitization can happen. So conceptually, you do need to treat both of those at the same time for patients to get better as well. So that is kind of the main components of the theory behind it, but really just creating space, increasing blood flow. Again, the first 8 weeks are really what we call down training, right? Calming down both the peripheral, central nervous system, very important, as well as increasing space in that short spastic weak pelvic floor musculature, and the external rotators, the hip, we sometimes treat too. So the piriformis, the obturator, the quadratus femoris, superior inferior gemelli, depending on the exam, but those are also important for really opening up that obturator canal area where the nerves flow. And then when patients are better, the physical therapist and us, we feel they're ready. Then we say, okay, now it's time for that neuromuscular reeducation program. Like now you're ready to start getting that lift, but you don't want to clearly do it too soon. So that's conceptually what we're doing, really similar to what you do. It's just this is the tool we have, and we just feel it just honestly helps sometimes get patients better faster, because we all know in this world, if the longer the pain's there, the harder it is for us to make it go away. It's just that chronicity. That's all it is. You don't want it to be your normal yet. You want it to kind of go away faster.
Absolutely, allowing for that reset so that the neuroplastic changes can happen a little bit sooner.
Exactly. Completely agree. That's exactly right. Resetting, retraining, like an iPhone. I tell patients it's like an iPhone, which is why, one treatment, if people come from far away, one treatment really doesn't do anything, because you can't reset and retrain conceptually in one treatment. You need to repetitively kind of desensitize and decrease that inflammatory soothe.
Great. So to finish up, any final tips for pelvic health and wellness that you wanted to share?
Yeah, no, for myself as a patient, I think the one tip, if I could give everybody, other than the mindfulness and breathing, is when you're ready, the yoga, the restorative yoga. Either Your Pace Yoga by Dusty and Miller or Adrian's yoga for the pelvic floor, both restorative approaches. But they're just amazing in terms of, once you work so hard to make all this progress, they really hold your progress nicely. They really work on continuing to really open up the pelvic floor, as well as strengthen those hip abductors, so you get that lumbopelvic stability, which will allow you to do more and more exercise. So I find if you can do that 3 to 5 times a week, that is the best thing. I mean, it really, we always tell our patients, we love you, but if you do this, you probably won't need to see us. If 3 to 5 times a week is the best thing I've found.
Wonderful. Well, thank you so much for your time, Dr. Shrikhande. This was very informative, and I loved getting to hear from you about everything that you do. So thank you. For the viewers who are watching, if you were one of the first 5 who gave a thumbs up in the comments section, we will follow up with you so you can get your free virtual Pilates class. And I just wanted to announce next week we are continuing the Be Well Live series for the next 2 weeks. And on Tuesday, June 9th, I'll be speaking about fascia with Tracy Matthews, who's a Pilates master here in Brooklyn. And then on Wednesday, June 10th, 5:30 p.m., that's the time that we're doing these, I'll be speaking with Dr. Ben Taylor, who is an osteopath here in Brooklyn, and we'll be speaking about osteopathic tips on how to stay healthy at home. So without further ado, thank you so much, Dr. Shrikhande.
Thank you.